Welcome to the recorded sessions for the annual Clinical Assembly, the ACA 2021. Thank you to the ACA for the invitation. My name is Sumitra Khandelwal. I'm an associate professor of ophthalmology at Baylor College of Medicine in Houston, Texas, as well as the medical director for the Lions Eye Bank of Texas. I'm going to be talking about endothelial keratoplasty today and tomorrow. When we look back at the history of keratoplasty, its first case was actually in 1905. Lots of modifications, though, since then, and it is the most common tissue transplant in the United States. Corneal transplants have a very high success rate, and this is due to the fact the cornea is immune privileged, meaning it doesn't have blood vessels and it's independent from the rest of the blood flow. It instead relies on the limbal stem cells to provide its nutrition as well as keep its transparency, which is so important in order for patients to be able to see. And we've really started out with full-thickness corneal transplants, otherwise known as penetrating keratoplasty, as the traditional transplants. But as you look through the years, the blue line is full-thickness transplant as reported by the EBAA. A 10-year review shows a decreasing trend in these full-thickness transplants and an increasing trend in the green line called endothelial transplants, or partial thickness corneal transplants involving the back layer of cells of the cornea. The red line is ALK. And one would look at this and think, wow, so endothelial transplants started at a really low level in 2005, 2007, and slowly increased. But what also has contributed to this change in this data is actually that the endothelial transplant requests from the eye banks for partial thickness transplants that were cut by the eye bank were actually changed over the years. In the beginning, a surgeon would order a full thickness transplant and cut the tissue themselves, but then over the years, the eye banks were able to provide pre-processed cut tissue for the surgeons, and so the reports of endothelial transplant were even more accurate over the years. And what is this broad category of endothelial keratoplasty? Well, you can start with Decimase stripping endokeratoplasty, called DSEK, and then even thinner, you can have just the endothelium, also known as Decimase membrane endothelial keratoplasty, or DMEK. The cornea has 5 layers, and the DSEK tissue essentially has the back 2 layers plus maybe a little bit of the stroma, so maybe 2.15 layers, and the DMEK is just the endothelium with Decimase. What you see is that the DSEK tissue comes in a few different types. You've got DSEK, D-S-A-E-K, which is Decimase stripping automated endothelial keratoplasty. You even have people call this DLEK, or Decimase lamellar endothelial keratoplasty. Much of this overlaps, actually. And then under some of the other types of transplants, you even have something called pre-Decimase endothelial keratoplasty called PDEK, and then also ultra-thin DSEK, or UT-DSEK. So lots and lots of letters to describe lots of parts of the cornea, a little bit of alphabet soup, so to speak. So let's kind of focus on the 2 most common words that are used for partial thickness transplants, DSEK and DMEK. The domestic trends have shown that DSEK has stayed about the same through the years, and DMEK tissue increases in its requests. And DMEK has certainly shown to have better outcomes than DSEK. With DMEK, you see in the red line that there is an improvement in vision. So logMAR is the y-axis, and the lower on the scale, so the closer to 0, the better vision, actually. And so everyone starts out at similar poor vision preoperatively, but at 1 month, the DMEK, or the red, gets you closer to great vision compared to the DSEK. And this continues till 3 months, 6 months, and 12 months. So really better visual acuity at all time points post-operatively, including that 1-year mark. You see much better vision in these patients. What are the advantages and disadvantages of DSEK versus DMEK? Well, DSEK is a little bit thicker tissue, and there's much more ease of surgery in that you can really manipulate the tissue and not have to worry about crushing it or damaging it as much as DMEK. Plus, it unscrolls very predictably because of how thick it is. In addition, the tissue prep is much easier for the surgeon if they still choose to process their own DSEK tissue, and actually much easier for the eye banks to process DSEK tissue because there's a lot of wiggle room with how thick it can be, and you can get anywhere from 50 microns to 80 microns to even 120 microns. Sometimes surgeons prefer thicker tissue because it's easier to use during surgery. However, we've seen now that the DMEK has better visual outcomes, better patient satisfaction, and there's even studies showing less graft rejection because you don't have that stroma. Endothelial cell loss, we're still looking at studies, although some may suggest that there are decreased endothelial cell loss in DMEK. Part of this is manipulation of tissue and processing at the eye banks for both types of tissue. In fact, the outcomes are so much better for DMEK that the AAO came out saying DMEK is safe and effective, and it's superior to DSEK in regards to visual recovery, visual outcomes, rejection rates, refractive error, and endothelial cell loss. And that error injection and repeat keratoplasty are actually pretty similar after the initial learning curve. And that means how many times you have to rebubble and how many times you have to go back to the operating room are similar between DSEK and DMEK, but you may have a little bit of a learning curve, which is something so important. So how can we make it easier? Like, why is everybody not doing DMEK? Well, some patients are just not candidates for a DMEK, and we'll go over some of those criteria. But also, there is a little bit of concern. I have very great colleagues at other places that do not do DMEK, even though they are excellent surgeons, and they just simply are intimidated by the idea of doing a new surgery and one that has a learning curve. So how can eye banks, how can others help assist in this learning curve? Well, there has been lots that has gone on to help with this. One is pre-stripped tissue and even preloaded tissue, as I'll show you later. And by this, one of the challenges is you order tissue and you have to strip it yourself as a surgeon. That takes OR time. There's a certain technique to it, and you can damage the tissue, and then you're up a creek because you're in the middle of the OR and you have to cancel the case or have backup tissue available, and that's a cost to your surgery center. The pre-stripped tissue is excellent because that's one of the more difficult parts, and you can have that tissue available for you and then just load it yourself. There's also better S-stamping. S-stamping is important because in order for DMEK and DSEK to work, you want to make sure that the tissue is aligned in the correct orientation, meaning it's not upside down. You want decimase and endothelium to be in the correct orientation as far as the 5 layers of the cornea. And if it's flipped, then the graft will not stick. Well, how do you do that in DSEK or DMEK? Well, DSEK is really easy because it's thicker, and so you can actually mark the cornea yourself. But DMEK, you cannot touch the cornea yourself because you may damage it. But the eye banks now can do what's called an S-stamp during their processing, and that allows them to mark the cornea in a way that you can visualize it. There's also been a lot of technique tips, and one of the keys is to overstrip the recipient, meaning even if you have a 7.5 millimeter DMEK graft that you're planning to inject, you actually want to make your stripping or the removal of the of the patient's cornea 8.0 millimeters, for example. So overstripping can help because there's a lot of improvement and give in DMEK, and it's better to have more of a larger stripping. And there's also some options for practice and learning curve. There's dummy versions out there. There's lots of wet labs available. There's even the ability to use some of the tissue that comes and do what's called the space monkey, where you're basically using that tissue and trying to get it to unfold for you. We talked a little bit about preloaded DMEK. This has been really great for us because the tissue will actually come either in a Jones tube or a goiter cannula or whatever type of tubing the eye bank uses. It'll already be scrolled perfectly in position, and your goal is to just load it onto a syringe and inject it in the eye. So here's an example, for example, where you've got the tissue and it's free floating in this tube, and you hook it up to your cannula, and then here we're going to inject it, much like you would do with an IOL, and the key is not to let it flip right out of the wound. So that's actually my fellow doing that, and I'm going to make the DMEK in an orientation that doesn't come right back out. But that really takes off a good 15-20 minutes of the prep that surgeons would have to do during DMEK. That's what we all had to do in the very beginning. And so this preloaded DMEK can take at least one aspect of the learning curve off the table. There's some other options too. Not all DSEK is necessarily going to have worse outcomes as far as vision goes. There are some patients that need to have a DSEK, for example. And so DSEK tissue less than 90 microns is considered ultra-thin DSEK. And it may require differences in techniques, but really do see some better visual outcomes in ultra-thin DSEK compared to regular DSEK if the patients are candidates. And the studies range in surgeon experience. There's no doubt, having trained many fellows, the thinner the DSEK tissue, the more it behaves like DMEK tissue. And so the techniques to unfold and move it are a little bit different as well. In addition, thicker DSEK tissue, you can just move it where you need to be, whereas ultra-thin DSEK, sometimes you have to use some of the DMEC techniques to move it. And there's something that I don't have much experience with, which is called pre-decimase EK, or PDEC. This is where they're able to keep dura layer, which is a 30 micron addition to, say, DMEC tissue. What that actually allows, one of the things with DMEC tissue is it oftentimes needs to be a particular candidates for DMEC. Oftentimes, the older tissue will not scroll as much. Younger tissue will scroll, making it more difficult to unscroll. And so the ideal DMEC tissue is non-diabetic, phakic 60-year-olds or plus who've not had refractive surgery. I live in Houston. That's really hard to find that group of patients. That being said, with preloaded DMEC, we can get much younger patients because when it's in the scroll, in the preloaded, it tends to unfold a little bit better. But in other countries, like, say, India, PDEC is very popular because that allows more patients to be able to be donors and to be processed for endothelial keratoplasty for eye banks. And the eye banks there are very well versed in how to prepare the tissue, but it is a much more difficult preparation for the eye banks. And here you have some examples of that, very good outcomes with it, with just that additional 30 microns of dura that allows for the tissue to unfold, even if it's young tissue, like 5-year-old tissue, 10-year-old tissue, 15-year-old tissue. There's also some alternatives to lamellar keratoplasty. You can have a decimeter rexus without grafting. You can add some eye drops to help with that. There's even new disruptive technology out in studies about injection of cultivated endothelial cells. So we're going to start with decimeter rexus, where you, instead of removing decimase and putting a new lamellar transplant from a donor in its place, instead of making an 8 millimeter removal of decimase, you make a small central 4 millimeters. And the idea is that the peripheral cells will then migrate to the center and provide a nice, clean endothelial layer there. And so in one study, about 4 out of 13 patients had cleared in 1 month. In 6 months, 10 out of 13 had cleared. Of those 3 that did not clear, they ended up needing endothelial keratoplasty. So it's actually really interesting. You don't have to worry about a transplant. You don't have to worry about being on steroid eye drops afterwards. You don't have to worry about rejection per se. But, that's a long time. Only 4 out of 13 had cleared at 1 month. 6 months is much longer than even DSEC. 3 eyes ultimately need an EK. And so you really have to have patients that are very, very patient with the process. And this is something that we have done for patients who have kind of milder, more central guttae, or who are phakic, meaning they have their cataracts still in place, and the act of doing a partial thickness corneal transplant with the donor may make their cataract progress, perhaps. And so it's something that the patient, though, has to be well counseled about the recovery. But it's a lot of time. So what can you do to make things faster, actually, in these patients? Well, you can add an eye drop, actually. So ROC, or Rho kinase signaling, is serine threonine kinase. And its inhibition can enhance proliferation of cells, lots of cells. But in this case, it could promote the proliferation of endothelial cells and suppress the apoptosis of these cells, and promote cell adhesion, which is actually kind of key in this growing of the endothelial cells and how they migrate from the periphery to the center. And there's 2 that enhance the rate of wound healing. For these cases, if we decide we want to use this, we actually have to order it from international and from Japan, which has been a little bit of a challenge over the last year due to COVID. But this is something that is not available at this time in the United States unless you go through special compounding. And there's actually some great options that actually can get that alone. You can actually see improvements in corneal edema. This is pre-treatment, and then 6 months post-treatment for endothelial cell dysfunction. And then if you do something like, say, decimase stripping, this study looked at 12 eyes, and then they used the ROC inhibitor, and there was clearing after 2 months in these eyes. And 3 of these required other treatment. 2 cleared, just needed more time, but 1 needed a transplant. That's much better than the initial, just the decimeter rexus or decimeter stripping. And then perhaps in the future, we won't need to do any endothelial keratoplasties because we'll have the injection of endothelial cells with this ROC kinase inhibitor. This is a study, a consecutive 11 patients with PBK, or bullous keratopathy, corneal edema after cataract surgery. They had endothelial cells that were processed or cultured. The kind of hand-picked generated cells were removed in the bunch. It's interesting because one donor in this type of thing can give about, several injections. And passage cells were injected with ROC kinase inhibitor. And the patient's actually in the prone position for 3 hours after surgery. Usually after DMEC, we have them in the prone position for 1 hour. But in these, they're prone for 3 hours. We have a supine position. And actually here, they're prone for 3 hours. Interestingly, though, it got very interesting outcomes. At the 1 month mark, you saw an improvement in corneal thickness that continued to improve up to 12 weeks, actually. And best corrected visual acuity dramatically got better at that 12-week mark and continued to improve up to 1 year to 2 years. And one could say, well, why not just do a DMAC? But in this case, we're talking about a procedure where there is no donor tissue needed, no expensive donor tissue via the eye banks. One donor can provide tissue for many patients. And the idea of rejection, which hasn't quite been studied in this, is probably not there because endothelial cells, as we mentioned, part of the cornea, are immune privileged. And so this is just a really intriguing way to go. I think we're a little years away from this, but it's in international clinical trials and probably will be coming to the U.S. And it's very exciting to see where this is going to go as far as endothelial cell injections, and is it going to replace corneal transplants. Here are some patients, for example, before injection, you see quite a bit of corneal edema, and then at 2 years after cell injection, you can't even tell that they ever had a problem in that eye. So where do we stand now, though? So with DMAC, this is preferred endothelial keratoplasty for most surgeons who do DMAC. Any chance I can, I will do it. I used to not do it even in eyes that had trab or maybe they were high myopes, but I actually do it in everybody because I think everyone deserves a chance for a DMAC, except some of these patients that have tube shunts. So I certainly do not want a DMAC tissue to go up the tube. Any patients who have iris pathology where the graft would not be able to unfold, or any eyes that are, say, unicameral, meaning that there's no lens, there's a way or a caveat or a way for the DMAC tissue to go to the back of the eye. And it's challenging in some eyes. It's challenging in post-trab eyes. It's challenging in post-vitrectomy eyes. And so sometimes I'll counsel the patient and they'll choose to do a thin DSEC instead. And then we still keep PKPs for full thickness pathology, things like keratoconus where DALK may be preferred, corneal scars, or they're just not unable to have an EK. Maybe they can't position, for example, afterwards. But we'll see what some of these disruptive technologies hold in the future as far as endothelial cell injection, for example. So the trends in keratoplasty show decrease in penetrating keratoplasty, being replaced with some endothelial keratoplasty. There's options for treatments, perhaps, to delay or even prevent the need for keratoplasty. And future advances may require no keratoplasty, which is always very exciting and interesting. Thank you for your time.